I'm very, very happy to introduce our next speaker, Dr. Merete Hagen, who has worked in Norway, Denmark, and currently UK. Dr. Hagen is consultant neurologist and senior lecturer at the National Hospital for Neurology and Neurosurgery, Queen Square. She has done great work in spinal cord injuries and autonomic neurology. And as we all know, small fibers are not only somatic. And if anyone, then the autonomic unit at Queen Square can teach us how to test the function of autonomic nerve fibers and what information cardiovascular nerve fibers can give us. So please go ahead.
Thank you very much, and thank you for inviting me. And well done to you. It's you are an hour ahead of us, so it's late afternoon for you. So well done on a Friday evening. So I'm going to talk about investigations of the cardiovascular autonomic nervous system. When I see a patient, let me see if I can move. Yeah. So when I see a patient in clinic, we know that if the autonomic nervous system is affected, there is a raft of things that can go wrong. Sleep, respiration, blood pressure, heart rate, endocrine, digestion, bowel. There's a lot of function that can be affected with an autonomic dysfunction. And when we see the patient in clinic, I always ask about all the different functions and systems, but what we're going to deal with today is the blood pressure and heart rate, which is the main thing we are looking at. We do to some extent look at temperature control and sweating, but I won't cover that today. So we use Finapress or the Nova to monitor the blood pressure and heart rate, which is a finger arterial sensor which the patient has on his hand. We need to have equipment. We need to make sure if there is a cardiac arrest that we can resuscitate. We use just bottles, drinking bottles filled with hot water to warm up the hands, because some of the patients have quite cold hands. So that's an easy way to heat them up and get a better blood pressure recording. When we test them, we look for autostatic hypotension by doing passive head-up tilt and sit-up and active standing. We do pressure tests to test the sympathetic vasoconstrictor and parasympathetic cardiac function with respiratory testing and postural change. So going to the autostatic hypotension, we know that when we change position, there will be a slight rise in blood pressure, not massive, but quite a slight rise, and in heart stroke volume, and a vasoconstriction to keep the blood pressure up. We expect that the blood pressure and heart rate, blood pressure is stable with a heart rate rise upon changing, and we test the patient for lying and seated for 3 minutes or tilt and standing for 3 minutes. We use a tilt table test where the patient is resting supine first. When we have a stable blood pressure and heart rate, we then tilt them 60 degrees head up. We know that when you change position, there will be with autostatic hypotension, you have a blood pressure drop of more than 20 millimeter mercury systolic and or 10 millimeter mercury diastolic on head-up tilt or standing for 3 minutes by definition. There are 3 types of autostatic hypotension. It's the initial fall, which is transient within 15 seconds, and it's a bigger fall. It's more than 40 millimeter mercury systolic and more than 20 millimeter mercury diastolic. And then you have the common one, which I already mentioned. And then we sometimes see a delayed blood pressure reduction after more than 3 minutes of standing. Typically in spinal cord patient, I see this about 10-12 minutes of standing or head-up tilt. The patients are complaining about cerebral hypoperfusion, dizziness, visual disturbance, loss of consciousness, cognitive defects. the typical coat hanger pain, which is pain in shoulder and neck muscle. It's specifically trapezius that shows pain, which goes away as soon as the patient lays down. We have also seen that some of our patients with autonomic failure complains about a low back pain, which has the same pattern resolved as soon as they lay down. They have renal hypoperfusion leading to oliguria, and then they have the non-specific weakness, fatigue, lethargy. On a head-up tilt, for a healthy person, we tolerate a head-up tilt for 10 minutes without massive changes in blood pressure and heart rate, while on a pure autonomic failure, here you can see that the blood pressure falls dramatically, while the heart rate is just steady on because it's not reacting at all. So the patient is not able to increase the heart rate when the blood pressure falls. While in postural tachycardia, you see an extreme heart rate rise, or per definition more than 30 beats per minute, upon standing or head-up tilt like here. We look for syncope. There are these vasovagal syncope, which can be either vasodepressor, cardioinhibitory, or mixed. Then you have situational syncope and carotid sinus hypersensitivity. Vasodepressor syncope is the most common one. I would say more than 96% of all fainters have a vasodepressor syncope. And you can see that the heart rate tries to increase but can't keep it up, but it never goes down profoundly. The cardioinhibitory syncope, that's for the cardiologist to deal with and get a pacemaker. We usually have one per month, roughly, with a cardioinhibitory syncope, but then we run 3 tilt table tests parallel each day. So we do see quite a number of patients. Then you have the mixed syncope. We know that the cardiologists, they love to give nitroglycerin. I would say that's not very useful because unless you have a heart issue, an angina, you're not using nitroglycerin on a daily basis. However, a venipuncture, something that is a pain, causing pain, could induce a syncope. And here we are using venipuncture as a trigger. And in this case, you see that there is both a blood pressure and a heart rate drop. When we are unsure whether this is actually a cardioinhibitory, we repeat the test with atropine, keeping the heart rate at 120 beats per minute steady, and repeat the testing. If the patient faints, okay, it's the vasodepressor part which is the driving force, and the patient may not be will not have any help from a pacemaker. If they don't fall or faint, well, then they need a pacemaker and send them to cardiology. Situational syncope is quite common. Defecation syncope, mixturation syncope, typical in Parkinson patient and autonomic failure. Elderly men in the middle of the night having to open their bladder and then they faint in the bathroom. Cough syncope, we do have occasionally those, difficult to capture those. The same with swallowing syncope. And then you have the syncope during orgasm, which is something that the patient is not telling us immediately unless they feel that they are secure. There is not much we can do about the syncope during orgasm. They might have benefit from increasing their blood pressure. And then we recommend that the person is on the bottom and not on top during the activity, as it can cause quite a havoc for those who are involved. Sympathetic vasoconstriction, we do pressure tests. That is isometric exercise where you use 1/3 of a maximal force for 3 minutes. We do mental arithmetic for 2 minutes. That is 700 minus take away 7 or 400 take away 7. We do cutaneous cold for 3 minutes, and we expect a blood pressure and heart rate rise. Here you can see we are actually just using a blood pressure cuff. And on this, you see on the top, a healthy person having, I must just say that these lines here are just a calibration of the NOVA. So that's why you have these lines here. But in a normal, healthy person, you will have a response in blood pressure like here and heart rate, while in a patient with a pure autonomic failure, there is nothing happening. The same will mental arithmetic. You will have an increase during testing. Of course, that depends if the patient is actually collaborating and doing their best. And if they are very smart, it might be difficult to get them to be stressed during this part. Cutaneous cold is quite, it's a cold, an ice pack on the hand or on the forehead if there is a spinal cord injured. And again, you would expect a decent rise in blood pressure and heart rate, which is not happening in a patient with autonomic failure. We do parasympathetic cardiac function tests. That is Valsalva maneuver, 15 seconds at 40 millimeter mercury 3 times. Deep breathing, 1 minute, 5 seconds in, 5 seconds out. And then we do hyperventilation and respiratory sinus arrhythmia. And here we use just a simple way of doing it, or you can do a more expensive way of doing it. The Valsalva maneuver will look for the expected responses, that they have a heart rate fall, a heart rate rise, and then again a rise and fall during the phase 1 to 4. And we look for the blood pressure recovery time, which is dependent on the patient's age. So here you see a healthy on the top with a healthy Valsalva maneuver, while in multiple system atrophy there is a much poorer response and not a good the different phases are not according to expected. Deep breathing, again, pure autonomic failure patient, they struggle severely with deep breathing, and you can see here how little variation there is in the heart rate during deep breathing. So when we interpret this, we look at the sympathetic function for tilt and passive standing, active standing, blood pressure responses to standing and to pressure responses. And then we look at the cardiac parasympathetic function via Valsalva, deep breathing, and heart rate response to breathing. We call it normal if everything is fine. It could be early parasympathetic damage, which if you have one abnormal test. If there are 2 or 3, you have definitive an abnormal test. You might have sympathetic damage, or you can have a combined one. With regard to the sympathetic part, it's not uncommon that people don't work well on the mental arithmetic, or they don't perform optimal during the other tests. So the clinical scientists, they make a note of whether they were well performed or not. So here is one test which was done actually today. There was a blood pressure fall upon standing and increased heart rate upon standing, but that met the criteria. Oh, yeah, this is so new that it hasn't been filled out on top here. But here you can see that there was a nice blood pressure and not a very high heart rate rise, but there was a sufficient blood pressure rise upon standing during isometric exercise, during mental arithmetic. I don't think this person is an 18-year-old girl. She didn't want to volunteer much of this. There was a nice blood pressure but a heart rate drop during cutaneous cold. There was respiratory sinus arrhythmia during deep breathing, and the Valsalva maneuver was performed with a 3-way tap due to COVID, and it was normal with a normal Valsalva ratio. And here she had blood pressure, which did not fall massively during 5 minutes of stand. And on head-up tilt, she had a blood pressure increase during 10 minutes of head-up tilt with a normal heart rate. She had a prolonged head-up tilt for 47 minutes. She didn't faint. We can do additional tests, catecholamines, meal, exercise, 24-hour, prolonged tilt, thermoregulatory sweat test, and carotid sinus massage. We know that the adrenal glands are important for keeping the blood pressure and heart rate up. So with autonomic failure, especially MSA and PAF, we have less of adrenaline and noradrenaline rise upon tilt, and very often low basal CATs. A meal test, we look for a blood pressure drop after a meal. What we do is a pre-meal head-up tilt of 10 minutes. We give them a milkshake consistent of protein powder, glucose, and full milk. They rest for 45 minutes. We monitor their blood pressure and heart rate, and then we do a second 10 minutes head-up tilt. Normally, we would keep the blood pressure and heart rate stable, but if you have postprandial hypotension, you get a blood pressure drop, typical for autonomic failure. Here you can see a 24-hour blood pressure profile showing that there is some blood pressure drop after lunch, after dinner, substantial blood pressure drop, and typical in the morning after breakfast. Exercise test, we do a supine graded exercise test, which the cycle is on the wall. For a spinal cord patient, we have an arm crank test. Normally, you get a blood pressure increase with increased graded exercise, while in MSA and PAF, you get a blood pressure drop. And here you can see a blood pressure dropping during exercise and further after exercise. Carotid sinus massage, this is quite increasing frequency with advancing age. We test we make sure that they have a negative ultrasound of the carotids, and then we do a carotid sinus massage supine and tilted on both sides. And here you can see on the left-hand side, you have a severe drop in blood pressure during testing, while on the right-hand side, it's more normal. We do 24-hour ambulatory blood pressure profile, where we ask patients to monitor their blood pressure and do activities and use a diary to tell us what they were doing and their symptoms. Here you can see on the top a normal blood pressure with a nocturnal dip. You have then a non-dipper, or you can have a reverse dip. And with pure autonomic failure, the blood pressure is all over the shop. And like here, you can see a 24-hour blood pressure showing that they have blood pressure drop after meals, blood pressure drop in the middle of the night, typical a man getting out to open his bladder, and then low blood pressure with a blood pressure drop in the morning. And here, for a spinal cord injured, you can see that there is a kink in the catheter, they have bowel routines, they transfer, physiotherapy, all that is shown on the 24-hour. It's set to go off 3 times per hour during day and 1 time per hour during night, and then we ask the patient to do extra activities. So that was what I had to present, and I'm happy to take questions. Thank you.
Okay, thank you very much for the clear presentation. one question is, do you get referrals of patients with neuropathy with a question of maybe subclinical autonomic involvement? Or do you think there is a place for such an approach?
We do see typical diabetes patients. We don't see that many of them, but we do see, yes. And I do think there is more autonomic symptoms and neuropathy is in diabetes patients than we are aware of. Yes.
And can you distinguish between central and peripheral autonomic disorders on the basis of the pattern of abnormalities that you find in the tests you have presented?
No, we would do investigations. I'm just covered now the cardiovascular autonomic testing, but if we suspect this is a pure autonomic failure or an MSA, we would do MRI, we would do lab tests, we would do antibodies. So we would look for, and usually neurophysiology, EMG, small fiber. So this would be just a part of it.
But the cardiovascular tests themselves do not allow this distinction.
No.
Okay. I have a question. How to interpret the autonomic test results in patients taking antihypertensives or other medications?
Good question. So what we not infrequently see is that patients are overtreated for their hypertension, and then they get symptomatic with autostatic hypotension. And when you then correct and reduce the drug dose, they get better. We try to take away drugs that could interfere with the testing as much as possible. But of course, if you have hypertension, I wouldn't stop your drugs before testing. And that will, for some of these, will interfere with the catecholamine. So then we won't take catecholamine levels and measure that. Usually we measure it supine and tilted to see if they have a normal basal level and a normal response on tilt. But if they are with drugs that could interfere, we just skip that part.
Okay. And an unavoidable question, do you have any experience with autonomic nervous system problems in post-COVID patients?
Yes, we do see that. And yeah, absolutely. Not as many as, well, I do think a lot of patients are experiencing autonomic symptoms initially. We do get referred, we have a lot of long COVID in London, and we do get referred some of them. We see that they get better with over time. These are not the patients who were hospitalized, they were at home. We have had a number of doctors who were ultra fit, several marathon runners among them, and I do think some of them have sort of wanted to go back to pre-COVID situation very quickly, and they've been poorly, they've been supine for a period, and then they get tachycardia. We have a couple of fainters, and then tachycardia, and postural tachycardia has been for several of them, but we see that this slowly fades away over time. But it was puzzling to see how many were sort of, oh, I usually run 10 miles per week and now I can't do it. And it's sort of, okay, you might just take it slow. Okay. Start low, go slow. And that's what we recommend. Make sure that they have enough fluid and salt, keep their blood pressure up, and take it slowly, and don't rush out and expect that you are back on track immediately.
But you haven't found any autonomic dysfunction in them, really?
No, well, both syncope and postural tachycardia are intermittent disorders, which are benign, so it will resolve over time.
But no
major
sympathetic dysfunctions.
No autonomic failure. No.
Okay. Have another question. Is there any correlation between skin biopsy results and autonomic nervous system testing?
Yes, there are. We are not taking skin biopsies, so I don't have the experience of that. We do have patients who had skin biopsy which were abnormal, but because we are not doing it ourselves and that is in another hospital it's done, so unfortunately I can't say much about it.
Mm. Okay, another question. When looking for orthostatic hypotension, in your opinion, are head-up tilt test and active standing tests equal or interchangeable? Do you need a tilt table, or can you?
I think you can do a lot by just having standing up. Yes, I think you can do a lot. And I must say, I love the 24-hour, because if you can get patients to cooperate and give you the timing and activity and symptoms, and the way we do it, it gives us so much information, and you can discuss it with the patient. Very often I give them a printout of their 24-hour graph so they can see what happened and understand what's happening when they do activities. So yes.
Would there be a screening method for someone who does not have access to an autonomic unit?
Yeah, I would say have supine and standing up for 10 minutes, measure the blood pressure and heart rate every minute, and then have a 24-hour, and you get quite a lot of information with that, without having a very fancy and sophisticated setup.
Okay, thank you very much. Thank you again for joining us.
Thank you for having me.